Now, David, you are advocating, as well as some other people around the country, in terms of mapping biopsies using templates.
Sure. Just a couple of comments worldwide about MRI. Mark Emberton in the UK is probably one of the leaders in this area, and they're studying that right now prospectively. Somebody comes in, they get have an elevated PSA. The next thing they get is not a biopsy, they get an MRI. Their thought is, and they may be right, is that if a lesion's discovered on MRI, it's a significant lesion, and they don't care about missing the insignificant lesions. I'm not sure I buy that yet. But I think what Dr. Quinn mentioned about doing MRIs and active surveillance, if that's all you're going to do, is not a bad thought, because you may miss an anterior tumor, and that's the risk. But now we have markers to help us with that, and we have markers to help us to tell us when to re-biopsy people. So you had mentioned our work with, it's called Transperineal mapping biopsies. Living in Colorado, we know if you drill more holes, you find more oil. And so what happens, I think there are two issues where we use this, two places. One is, in somebody that's had negative biopsies and you worry you might have missed something, we have some new markers called Confirm MDX that help us, but we still miss stuff. And we've shown very clearly that when and by a transperineal mapping biopsy, we have the patient in a perineal position. We use a template. We go 5-millimeter intervals, and we may do 100 biopsies in a gland. It's usually 2 biopsies per gram. So we'll find cancers maybe 30–40% of the time that were missed, and some of them significant, not just insignificant cancers. The other place for these transperineal mapping biopsies are in men that have, in quotes, a low-risk cancer. And knowledge is power. You know, if you think about every cancer that we kind of treat, we stage it. We do PET scans, we do bone scans, we do all these other things. In prostate cancer right here, it's not valuable. We're making basically life and death decisions on random transrectal biopsies. And we've all seen where people have had biopsies positive on the right side. You do the radical, the cancer's on the left side. How did that happen? They got mixed up. And so, this provides more information. And what we've shown is by doing this, and we've done about 800 of them right now, that doing this is just as accurate, if not more accurate, than a radical prostatectomy in finding out what's going on. And we'll see a lot of people, and our numbers are this: about 30–40% of people have one core, Gleason 6. You say, okay, let's do active surveillance. We do these biopsies, and we'll find higher grade disease, Gleason 7s that are hidden, a lot of them transition zones. So knowledge is power, and I think that the more biopsies are better. That it does take time. It's expensive, but I think it really, there's a lot of confidence that you have when you've done that and you know what you got.
There's also a lot of cost. There's also a lot of morbidity to it, and that's the assumption that every small focus of Gleason 7 needs treatment. And there's actually some data that Gleason 7s actually, low volume, actually do quite well in active surveillance.
Well, I would disagree with you about morbidity. There's actually very little morbidity compared to transrectal biopsies. You don't get sepsis and other things. The biggest problem you have is urinary problems afterwards. The transperineal mapping biopsies are actually relatively well tolerated.
In the clinic or in the OR?
We do them both.
Okay. So my question would be to you, David, is that going forward, we've seen this evolution from us putting a finger in and blindly biopsying the prostate. We've now gone to ultrasound and using a transrectal. Do you see the paradigm shifting in the next 5 years where patients are going to come in and we're going to be doing transperineal biopsies on all these patients? And, obviously you say the risks of sepsis and other things are lower, but, do you think the experience is large enough to say that you've got that experience now over time?
Well, I think we do actually have that experience. If we look at this, if you look at costs, the cost right now, the reimbursement, what Medicare has done is they put number of biopsies in buckets. So you can do 100, and you're just going to get paid for 30 biopsies or 25. So there is a factor, but we're getting better at processing these things and quicker and things like that. And we do this 3D reconstruction. Why is it that so many urologists don't support active surveillance? Because in the back of their mind, they know a bunch of radicals they've done. and they have Gleason 8 cancers. They missed it. And I can tell you the multiparametric MRI, everything else is not going to change that. So right now the mapping biopsies give us some good information. And you know, you can decide if you want to have, you know, active surveillance, if you want to ablate it, and a lot of people do. If you find a small cancer, Gleason 6 or 2 or 3 or 3, 4, 7, you can ablate them. You can ablate them with cryotherapy. Or, you know, if you have worse disease, then you do some definitive radiation or surgery.
I think the point really is the fact that we need to move past just traditional 12-core ultrasound-guided biopsies. We do a poor job in sampling the prostate. I think there was that paper published from Johns Hopkins a couple of months ago that looked at patients that had undergone radical prostatectomies who would have been categorized as low risk or very low risk patients that had all undergone radicals. I think there was, 7,500 patients, and 25% in the low risk category ended up having upgrade of their Gleason, and 20% ended up having extracapsular disease. And in the very low risk category, I think the numbers were like 13 and 8%. So I think the bottom line, as we all agree, I think that we need to do a better job in accessing, sampling the prostate in order to make an appropriate recommendation for active surveillance. And there's going to probably be a number of things involved here. Imaging, whether it's mapping biopsies, the use of biomarkers, I think they'll all be quite useful for our patient. But I think it is important that we as urologists, and again, I am a firm believer that I want the urologist to continue to be engaged, continue to be the purveyors of prostate cancer, continue to be active in the biopsy realm, needs to start to understand this.
So one of the things we're doing, I mean, I think the mapping biopsies give us some immediate gratification, but you can't, that's not going to go forward in that strong. So what we're doing is we know there are epigenetic changes around cancers. Maybe you can do a fewer biopsies. We're looking at that, biopsying critical areas. If they're negative, then you can treat the rest of the prostate and leave the nerves and the apex around. So, I mean, this is just a new frontier, and it's exciting.
Right.